Good morning, everyone. It's my pleasure this morning to introduce Dr. Jennifer Kelly. Dr. Kelly did her undergraduate in psychology at the University of Washington and then got her doctorate from the Washington School of Professional Psychology. And Dr. Kelly is a member of our Pain Collaborative and Opioid Guiding Team. And that group contacted me several months ago about possibly doing some more education in this regard, which was timely because it was not long after that we got the mandated education that I'm still trying to sort through and figure out myself for opioid training to get our DEAs. So keep this lecture in the back of your mind and know that you did it because it might count for 1 hour towards the 8 hours that are required. But we'll know more about that in the future, and there will be other alternatives as well. Dr. Kelly is going to talk today about compassionate limit setting. Go ahead, Dr. Kelly. Thank you.
Thank you, Dr. Nietzsche, and thank you so much to the CME team for having me. I've been at Virginia Mason almost 9 years now, and I've never presented Grand Rounds, so this is very exciting for me. Before I start in, I want to just give you all a little bit of context and background for why I'm presenting this topic to you. And by the end of this hour, compassionate limit setting will make sense if it's a confusing term right now. Back in 2017, I was approached by Dan Warren, who asked me if I would be willing to join the compassionate limit setting faculty and create a curriculum. This was part of Virginia Mason's kind of broader opioid stewardship work. We were hearing from providers, primarily primary care providers, that they were feeling not fully equipped to navigate the often emotionally charged or challenging, at the very least, discussions with patients in the context of chronic opioid therapy prescribing. And this was a time, after those prescribing guidelines had changed around safety and risk, and providers were kind of feeling stuck a little bit between a rock and a hard place, needing patients to taper their chronic opioid therapy doses down to safer levels. Patients who'd been on those medications for a long time naturally being somewhat resistant to that. And so what we wanted to create was a curriculum that would help empower providers to navigate these challenging discussions. So we put our heads together. It was a team comprising of multiple disciplines, lots of talented people. And we created a curriculum, and then we took it on what we lovingly called a road show. We went around to various regional medical centers, primary care sites. We went to Federal Way and Kirkland and Linwood, right here in downtown primary care. We presented to our nursing team at a CNE event. We presented to the inpatient hospitalist team. That was in 2021. So as you can imagine, that one was over Zoom. But it was a great experience, and we learned a lot from it. And we kind of evolved and changed the curriculum over time and tailored it to our audience. What I'm going to present to you today is just my portion of the broader compassionate limit setting curriculum we created. Suffice it to say, there were lots of other very important elements involved, especially Dan Warren's discussion around the history of opioid prescribing, where we're at now, how opioids hijack the brains of our patients, how stress hijacks our brains in the moment when we're feeling stressed out. So my portion kind of focuses on the tools and the strategies for navigating these conversations. And the folks at the CME department here are brilliant because they made my job very easy. They scheduled Dr. Justin Brandler to present last month all about neurogastrocompassionology. I hope I said that right. I practiced it. And he presented such an informative talk about the data, why compassion is valuable in healthcare, helps prevent provider burnout, helps improve patient adherence to treatment, improves rapport, reduces cost. So he did all that work for me, which is really nice for me. Consider my talk kind of a follow-up to that, where I'm really going to be focusing on the how. So one of the major pieces of feedback we got when we were on the roadshow back in 2018 and 2019 from providers was, look, I fully appreciate and understand that compassion is important, mindfulness is important. How do I actually convey it? What does that look like? What are the things that I need to be saying and how do I say them? In other words, I need some scripts. And so that's what I'm here to give you today is a lot of scripting. So, phrasing, questions, tips and tricks about how to convey information to your patients in a compassionate way. And so I will say one caveat to that. I'm a pain psychologist, and my whole world is chronic pain. And the compassionate limit setting curriculum was developed in the context of that chronic opioid therapy prescribing. So a lot of my examples are pertinent to pain and chronic opioid therapy. But you can extrapolate a lot of those examples for whatever your practice is with patients. And Rich Furlong, as part of the controlled substances guiding team, brought up the excellent point when I presented to the quarterly meeting that a lot of these skills can be applied in really any situation where you're faced with a challenge with a patient. Maybe you're making a recommendation about the need for some sort of behavior change and they're feeling resistant to it. Maybe your patient is not adhering to recommendations for treating their diabetes. Maybe they need to reduce their BMI in advance of total knee replacement. Maybe they're smoking and you want to have a discussion with them about smoking cessation. So suffice it to say, hopefully these skills will apply in different settings, but my examples all have to do with pain. I will say one last thing. I promise I'll get started eventually. I don't love having wordy slides, but in this case, it's necessary because I want to give you that scripting. I want to give you those examples. So I've written them out in full detail. And in fact, the last part of my talk this morning is giving you pocket cards, which come from the Oregon Pain Guidance Organization. And those are great because you can literally print them out, put them in your pocket, tape them up to your flow station if that's allowed, or put them up in your office, and just having those cues and those reminders of what to say, grounding yourself before you go in that exam room with that patient can be really helpful. So I'll go ahead and start now. And I'm going to speak with you today. Oh, can I? Yeah, perfect. We're going to start with setting expectations and providing patient education, because that's often where these conversations start. And it really sets the tone for how that experience is going to go in subsequent visits. We're going to talk about compassionate limit setting skills, and then I'm going to go over motivational interviewing techniques because those are great ways to help move conversations forward and to help reduce the emotional intensity of conversations if you notice that that is starting to increase. And then, of course, at the end, I'll show you those pocket cards. I have no disclosures to report. So starting with setting expectations. Now, imagine you're in the first visit with a patient. You've reviewed some of their records and you kind of have a sense of what's going on, and you have some ideas or recommendations in mind. Of course, that depends on your exam and the information you gather from the visit. Or maybe you've inherited a patient from a provider who's retiring and you're kind of looking at the things they were doing and you have some new ideas to bring to the table. Setting expectations for your patient that they will get better by offering a believable path forward is really powerful and really crucial to do at the beginning. I don't know if others have attended pain medicine conferences in the last couple of years, but those are the ones I tend to go to. And I've been really interested to see a lot of new research coming down the pipeline about the power of predictions, these self-fulfilling prophecies that we set that really determine outcomes and experience. Your patient is coming to you as the clinician to give them recommendations based on your expertise. If you tell them with authority, I think you will get better, and here's a believable way forward, they're more likely to succeed. When we predict that outcomes are going to be good, we tend to engage in the behaviors that are required to reach that outcome. And then when that outcome comes to pass, it confirms the prophecy and it creates this kind of positive feedback loop. Now, we want to be realistic, of course. You're not going to tell your patient, I'm going to fix everything and wave a magic wand and everything's going to be great. But if you offer them a believable path and you encourage them and say things will get better, they are more likely to get better. And setting that expectation is really, really key. There have been a number of studies, and like I said, more coming down the pike about this topic, that when patients expect that they're going to get better or expect relief, they actually rate their pain as lower in the moment. When they're told that something is going to hurt or their pain is going to get worse or it's going to last forever, hopefully nobody says that to their patient, or they anticipate discomfort, their pain goes up. And this has everything to do with the threat perception. You know, our brain is a prediction machine. It's constantly assessing for threats. And if we're expecting relief, we're going to feel better. If we're expecting it's going to get worse, we're going to feel worse. So this is a crucial intervention and a great way to set the stage with your patient for your ideas about what you think will help them. Now, when we're setting expectations, we want to also communicate what our goal is at its core. I want to help you live a life that is as close as possible to the life you intended to have before this issue began. Patients really appreciate hearing this, and I know it sounds like a minor thing and it's obvious, but when you put words to it, you're telling them, I value your quality of life. I value your functioning. These are the things that the patient cares about and wants to optimize the most. And if they believe that you really care about that, that goes a long way. When setting expectations as the patient, especially in the context of, making some sort of change, it's helpful to share anecdotes and stories that stick. We can tell them, randomized controlled data all day long and their eyes will glaze over. But if you tell them a really impactful story, using a real specific example, that information will be more likely to stick in their brain and they'll remember it and carry it with them. So I work with a lot of chronic pain patients. Sometimes they are needing to taper their opioid dose down, or maybe they're wanting to come off of it completely. And if that's the case, I'll share anecdotes that are true, of course, with no identifying patient information. But generally, I worked with a patient who tapered her opioid dose, and after she was done, she said she felt like she got her life back. And I just wanted to share that experience because I thought that was really powerful. And in fact, I told that to a patient just this last week who's contemplating coming off of her hydrocodone because she went through my classes, she created a toolkit, she's gotten back into swimming, her fibromyalgia is under control. And she's like, I don't really feel like I need the hydrocodone anymore. I shared this anecdote and that really stuck with her. She said, okay, now I'm picturing a real person who's dealing with my same kind of issue and they're on the other side of it. And it was a positive experience for them. That gives me hope. Now, some patients will want data from studies. And so sometimes I'll summarize the study. I love the Darnall study, the Stanford study from 2018. This was looking at voluntary opioid taper in an outpatient setting. And what they found was that patients who tapered their opioid dose, some just reduced it, some came off entirely, either reported that their pain stayed exactly the same as before, or that it went down in many cases. Nobody reported that their pain went up. And so I'll share that information too, because I'll say, it sounds kind of paradoxical, but this really robust study showed that patients' pain stays the same or even goes down when we reduce that opioid dose. And patients are hungry for information. That's one thing that I've learned by teaching my group classes to patients is they want to learn. They feel empowered when they have this knowledge. And it's really a great way to show compassion when you say, I value your ability to learn about your own condition and make your own choices about your care. So in the vein of stories that stick, I'm going to give you just a quick example of one that I use. This is again pertinent to the pain discussion, but find whatever anecdotes kind of make sense when you're relaying to your patient a complex idea, but you're wanting that information to stick. So I talk in my first class as part of my series to patients about pain neuroscience and how our brain's job is to save our life. Our brain's job is to keep us safe and be aware of any potential threats. Our brain will always use all the available information to assess whether there is a threat. And if there is, it will create pain to make you change your behavior, to get away from whatever the brain is perceiving as a threat. And so I'll tell them a tale of two nails. In 2007, in the Journal of Psychosomatic Medicine, they reported on two cases. Both were construction workers. The first one was on a job site and he jumped off a platform and landed on a nail. That nail went right through his boot, straight through to the other side. As you can imagine, he immediately felt excruciating pain. He looked at the horrified faces of his fellow construction workers. They rushed him to the hospital. They gave him a massive dose of IV fentanyl because he was in so much pain. And the doctors went onto the task of removing the boot and discovered that the nail had actually gone in between two of his toes. There was no wound, there was no tissue damage, there was no bleeding, but his pain was real. How is this possible? Well, his brain used all the available information in that moment to decide there's a threat. I see a nail sticking out of my boot, reasonable conclusion, it went through my foot, horrified faces of all the people around me. My brain decided there was a threat and it created pain to get him to change his behavior and address the issue. Now, there was another construction worker who was using a nail gun, and that nail gun misfired and it clocked him in the jaw. But when that happened, he saw a nail shoot out in front of him and land across the room. And he thought, thank goodness, I've narrowly avoided a catastrophic injury. I'm safe. He felt a mild kind of toothache, but he didn't really think much of it because, again, he thought he'd avoided an injury. He went on to live his life normally for 6 days. He went to sleep, he went to work. He finally decided he was going to go check out that toothache. He went to his dentist and had x-rays done, and they found a nail lodged in his face. So this really speaks to the idea that you can have pain without tissue damage, and you can have no pain, even though there is tissue damage, because your brain is using lots of complex information to decide whether to make pain or not. And so I'm sharing this with you as an example of an anecdote that really lands with patients. So when I present this in my class, I give them a ton of information. This is the one thing they always remember, because that's a story you don't forget. And it really, really helps to illustrate stories in that way that are emotionally salient, if you will. Again, our jobs as clinicians is to provide information to patients. They're not asking their barista for recommendations for their migraine headaches. They are coming to us for recommendations. When you give them information, I recommend asking for permission before you do so. I know it sounds like a small thing and it adds a couple of seconds to your time, but it goes a long way. Some of the opioid prescribing guidelines have changed recently. Would you like me to tell you more about that? Your body will adapt over time as your opioid dose is lowered. Would you like to learn more about what to expect? Nine times out of 10, patients are going to say yes. I'm interested to learn because they want information. But giving them the opportunity to decide is giving them some power back, giving them some choice and some control. And you're evening that power balance and allowing them to feel like they have some choice. That matters a lot when you're building your rapport with patients. We want to provide information about all the different treatment options that are relevant to their particular issue. Again, asking for permission before we do so. And it's important to think about the whole patient. And again, I'm speaking specifically to pain. We've historically taken a very biomedical approach to pain. Somebody has pain, so we say, okay, go see your doctor, get some imaging. let's poke and prod you. Let's figure out what's going on from a tissue standpoint. And we aren't necessarily always thinking about the whole person. Pain is biopsychosocial. So let's address it through other interventions as well. And so when you ask your patient, let's say, for example, you're saying, okay, I would recommend physical therapy to start, because maybe we want to start conservative before we get into more invasive interventions. And they say, no, I've tried PT 10 years ago and it made things worse. It didn't work. Okay. If they're resistant, we roll with it. We don't want to get in a back and forth argument with our patient because that doesn't serve us well. We can document that the patient is not yet in the contemplation stage of change and plan to revisit the topic next time. We discussed PT last time. Have you given any more thought to that? Resistance is natural to change, and it's okay to just roll with it. Let it happen, document it, and earmark it for next time. I'm going to say this in a few minutes again, but it's very unlikely that you're going to solve your patient's problem in that one visit alone. Usually it's a series of follow-ups and interventions, and let's check in and see how things are going. It's a process, and it's okay if they're not ready to make all the changes right there at once. And in fact, sometimes it's helpful if, let's say, if the change is you're recommending reducing opioid dose. That sounds scary because they're worried their pain's going to get worse. You can even tell them at the outset, look, we don't need to make any changes today. That will keep them in their wise mind, their prefrontal cortex, and out of their amygdala, their limbic system, because they're not going to be perceiving a threat, and they're going to be more likely to listen and understand and work with you. Okay, let's talk about the name of the game, which is compassionate limit setting. I give full credit to Dr. Justin Brandler for the definition of compassion that I'm using. Empathy in action. I think that's just such a perfect way to say it. It's empathy, but you're showing it, you're demonstrating it, you're using it. Now, as I mentioned before, our job as clinicians is to give the best advice to our patients based on what we know, based on up-to-date research, adhering to regulations and criteria. But we can only control our own behavior. So when I say compassionate limit setting, we're not setting limits on the patient because we cannot control what they do, how they think, or how they respond to us. We can only control what we do. So we set limits on ourselves, what I'm willing to give into, what I'm willing to do, how I respond, how I maintain my boundaries, whether I let those boundaries get crossed. That's where I set limits. We set limits on ourselves, not the patient. And that requires us to give ourselves permission to set boundaries, which we can do respectfully. And we can do that with compassion. Now, the goals of compassionate limit setting, of course, are first and foremost to convey compassion. Whatever the reason for the visit the patient is there for, it's probably presenting some type of challenge. Even if it's an annual checkup, like I just had mine last week with the wonderful Hannah Ryan in Bellevue Primary Care. And, I didn't really expect anything to be found in that visit. I thought everything would be fine, but there's always that thought in the back of your mind, like, what if my lab work doesn't come out well? What if they find something? Whatever the reason is, it's presenting some kind of challenge. We can empathize with that because we ourselves as providers are patients too, sometimes. Now, just as we extend compassion to our patients, we extend it to ourselves. We acknowledge that it's unlikely that we're going to fix the problem in this visit alone. Do not set unrealistic expectations for yourself. Be kind to yourself. What you want to focus on is planting the seed for future change with your patient. And the best way to do that is to capitalize on their strengths. So sometimes patients will come to me and they'll be like, I'm told I'm really stubborn about this and that. And I'll reframe it because I'm a psychologist. I love reframing. And I'll say, you're really determined. When you decide you want to do something, you stick to it. That's a good quality. Let's use that. When you highlight their strengths for them or reframe their negative self-talk as a unique strength, that goes a long way because they start to see themselves in that light. And sometimes I'll just tell patients, the things I notice, I can tell you're really interested in learning and growing. I can tell that that's really important to you to learn. And they'll say, yeah, I guess I've never really said that about myself before, but it's true. And then they carry that with them. And then they're more likely to be successful because they feel more confident. When we're setting these compassionate limits, the limits on ourselves, that means we're maintaining and we're respecting our own boundaries. And this is where we want to talk about the alarm system response, specifically fawn. So we all know what fight or flight is. Fight is approach the threat to get it to go away when I sense that there's a threat. Flight, the urge to run away from the threat. If I can't fight it or run away, I can freeze. That's the play dead response. That's the deer in the headlights, stuck, not sure where to go or what to do. In severe cases of exposure to trauma, people dissociate. That's part of that freeze response. Fawn is probably the least commonly discussed, but it's the most relevant in these conversations. We enter this profession because we care about people and we want to help them. And when we see somebody struggling and asking for something and we're not necessarily comfortable with it, but we have this urge to say yes because we want to make them happy or we want to avoid conflict. We might be more likely to say yes when we really want to say no. We might be more likely to let those boundaries get pushed just to avoid conflict. The fawn response is part of this stress response, by the way, because as humans, we're social creatures. And if we're rejected by the people around us or judged negatively, that's very threatening to our well-being and survival. So we have this desire to please others, to be part of an in-group. I bring this to your attention because, and I tell my patients this all the time, 75% of this game is awareness. If you can be aware that you're having an alarm system response in the moment with a patient, specifically fawn, because you have the urge to just write that early refill, even though you don't feel good about it. Sometimes all you need to do is observe it. I'm having the fawn response. You can even just say it in your head. When you observe it and you name it, you now have agency over it. Now you can be intentional about how you proceed. You're not just going through the motions anymore. Now you're naming this state and you're deciding what to do from there. Before I move on, I just want to say one thing about setting our boundaries and maintaining them. I like the analogy of thinking of a sandbox that has a bunch of toys in it. And those of us who are recovering people pleasers, we're told, okay, clean up the sandbox. Let me pick up everybody else's toys, mine and everybody else's. Compassionate limit setting is limiting your behavior. I'm not going to pick up my mother's guilt or my partner's debt or my boss's anxiety or whatever it is. I'm just going to pick up the toys that are mine and I'll leave the rest for others to take care of because those are theirs. These are mine. And that's really a great way to think about what compassionate limit setting means. Now, when we're in that alarm system state, I have some tools for you, some recommendations, because a lot of times people are like, okay, I get that I get stressed. What do I do when I'm in the moment? How do I work with that? These, by the way, are techniques I recommend to my patients, but we're all humans, so they help clinicians as well. The first one is a breathing exercise, which you could do like right before you go into that exam room with that patient, maybe that you're anticipating there being some challenging discussions. When you breathe in this pattern, it forces your heart rate to slow down. So you're inhaling for a count of 4, holding your breath for a count of 7, and exhaling for a count of 8, and holding and exhaling for a long time. That forces that heart rate to slow down to conserve oxygen. And that tricks your body into entering a rest and digest state, that parasympathetic nervous system response. Tells your brain, there are no threats to my well-being and survival. I can relax, start ramping up production of GABA, that lovely inhibitory neurotransmitter, slows the firing of nerves down. So it's really impactful in a short amount of time. And that's because it's actually a technique for panic attacks because it works so quickly in the moment. You can do it anytime, anywhere, because you have to breathe anyway to be alive. I've had patients use that, when they're stuck in traffic or they're waiting in the waiting room at their doctor's office. But it's something we can do just to bring that stress response down right before we enter that conversation. I'm, in the interest of time, not going to show you this video, but how to train your monkey mind is a great mindfulness technique that takes only 1 to 2 seconds, which I love because I'm a very impatient person, like the quicker the better. And so there's this Buddhist teacher who explains how to train your monkey mind and how you can meditate in one breath, 1 second. And so even just doing that in the moment when you're having that discussion with the patient, just to bring your own emotional intensity down goes a long way. It's almost like just pressing the reset button. I use it all the time. The self-fulfilling prophecies that help our patients when we're setting expectations that they will get better with a believable path forward help us too. Right before you enter that exam room, I will be compassionate. I will respect the patient and myself. I'm confident this will be a productive visit. Hold the belief that your patient can make helpful changes for themselves. Hold the belief that you can help them and this will be productive. It really goes a long way, that mindset. I'll just share with you a couple other tools that come from dialectical behavior therapy, DBT, developed by Marsha Linehan in our home state at University of Washington. The half smile and the willing hands, kind of similar to that breathing exercise. It's sort of about tricking your body into a state of calmness and confidence. So they often use this picture of the Mona Lisa because this is the half smile that we're talking about. So it's not a smirk so much as it's the facial expression you make when you're feeling at peace, when you're just feeling content and calm. Physically putting your face in that expression, in that posture, changes the communication going to your brain because now your brain says there are no threats, we're calm, we're fine. Same with willing hands. It's open, it's relaxed, it's confident. If I'm feeling threatened, what do? I close myself off and the patient gets that message. But if I'm feeling confident and open, I have my hands like this. So just that subtle change, putting your body into that posture changes your internal state just enough often to move things forward. Okay, let's talk about motivational interviewing skills now. Here's where we're going to get into more scripting. These are kind of the tenets of motivational interviewing. There's a lot more to this, but I want to, again, just get into the weeds with you with it so that you have the scripts to use. So the first technique for motivational interviewing is validation. This goes hand in hand with compassion. By the way, when you validate patients, you are not condoning their behavior. Like you're not saying it's great that you're smoking half a pack of cigarettes a day. You're just acknowledging their experience. I understand this is hard, or I can see this is hard, or I hear what you're saying. Using those senses can be really helpful. I can see you're feeling anxious, or I can hear frustration coming from you. It sounds like making changes is scary, or just this is really hard. Just putting words to that goes a long way. I think Dr. Brandler mentioned this, but depending on your rapport with the patient, you can say, I understand. And sometimes that can help, but it's almost better to just err on the side of using your senses. Here's what I'm seeing. Here's what I'm hearing. It shows that you're listening and you're not making assumptions like, oh, I know exactly what you're talking about. Okay, yeah. You're saying, here's what I'm hearing from you. I can't tell you how many patients come to me and they say, I just want people to listen to me. I just want them to hear where I'm coming from. They don't necessarily have to fix me, but I just want them to acknowledge that this is really hard. And that's why I do my classes in a group setting for patients because they validate each other. And sometimes that's the first time they've been validated. So it really, really helps. And it doesn't take much time. It takes a couple seconds. Conveying empathy involves a number of different techniques. So first, that skillful reflective listening, like you're reflecting back what you hear, maybe just in a slightly different way. helping the patient hear themselves and helping them see that you are listening. Affirming where they're coming from. I can see how that would concern you. I can see how that would be scary. I've mentioned reframing already, but it's a great technique for helping patients see their own strengths. I've tried so many times to taper and I always fail because my pain is so bad. You're very persistent. This change must be really important to you. If you're feeling stuck in the moment with a patient, sometimes it's helpful to bring words to that. Like, I am feeling kind of stuck as we sit here. I'm wondering if you feel the same way. Sometimes when we disclose our own emotions in the moment, it causes us to be more vulnerable, and that gives the patient back a little bit of power because they feel like kind of they're on the same playing field now because you're disclosing your discomfort and asking them how they feel. Amplifying ambivalence is useful in the context of the patient needing to make some sort of change. Often we're two minds about things. Things are very rarely black and white. There's always pros and cons to different options. And if you can highlight a patient's awareness about that, it really can be helpful. On the one hand, you've mentioned that you're still having a lot of pain and you wish you didn't have to be dependent on this medication. But on the other hand, it feels like changing that isn't an option right now. What do you think should be our next steps? So you're bringing their awareness to the two sides of the coin and then putting the ball in their court, giving them some power, some choice and control. And sometimes when you highlight that ambivalence, when they hear it back at them, they say, okay, I am actually leaning more towards this option. What are some of the pros and cons of taking this medication for you, or the pros and cons of starting physical therapy, for example? On a scale of 1 to 10, how ready are you to make some changes? 1, okay, that's fine. We're going to roll with it. But it helps to get that information and then help the patient hear themselves in the moment. We all know, I think, that open-ended questions are generally better than closed-ended questions. Attorneys, when they're questioning a witness on the stand, they use a lot of closed-ended questions because they're trying to control the narrative. They want a particular story to come out in a predictable way. As clinicians, we want the opposite. We don't want to control the narrative. We want to hear from the patient what their concerns are, what works for them, what doesn't, so that we can collaborate on a treatment plan. So those open-ended questions go a long way. Now, sometimes, and I've had this thought myself, sometimes I hear, open-ended questions take more time because then when I leave it open to the patient, they might talk for, 5 to 10 minutes when I could get the same information from a yes or no question. Well, I would argue that in many cases, open-ended questions actually get you more information faster, more information that is pertinent to that patient's issue. Like, have you ever filled out a form in the waiting room and it's like, are you having difficulty breathing? Yes or no? Well, if I answer yes to that, now the provider does have to ask several follow-up questions to kind of get at what's going on. How about instead, how is your breathing? Now I'm going to speak to what the actual issue is or the sensations that I'm having. So it gets at that information much more quickly. Now, the questions I have here as scripts are, again, in the context of chronic opioid therapy prescribing. Highlighting patients' awareness about the consequences, eliciting information from them about how they feel and think about the idea of tapering their medication. What things in your life are so important to you that you're willing to tolerate pain and discomfort in order to have them? That gets at that quality of life and functioning piece. And if you hear something in there that you can capitalize on, then run with it. Because everybody has things that are important to them. And one of the things I recommend to my patients is that they sit down as part of creating their pain coping toolkit. They sit down and write out all of their values, all the things that give them purpose and meaning, the things that get them out of bed in the morning, the why. And bringing that connection to that, even in a medical office visit, helps a lot because that's ultimately what the patient cares about, is their quality of life and functioning. We all do. Eliciting awareness to consequences of behaviors is helpful again in the context of you're recommending some sort of change needing to happen, and maybe the patient's feeling resistant about that. I'm worried about you and what might happen when you go home. We have some ways to reduce your risk, naltrexone, scheduled dosing. Would you like to hear more about those options, asking for permission? Or, I'm worried about these 3 medications. Which one is the least helpful for you? Or how do you feel about your day-to-day routine? How would you rate your quality of life and functioning? You're getting some information from them, and then you're going to use that in the next steps when you're creating your collaborative treatment plan. Okay, art of difficult conversations. Here's the pocket cards for you. Now, I'm just showing you 2 of them today, but if you look up, there's the website there, OregonPainGuidance.org. There's a number of other pocket cards that are really useful. And again, when we're talking about these skills and these scripts, it helps to rehearse them, as silly as it sounds, but just kind of practicing it over and over in your head, having go-to phrases that you rehearse. And I always tell my patients that, look, we're wanting to come up with helpful narratives about pain that help reduce the perception of threat, help build our confidence that we can manage it. And I tell them, you got to practice those narratives so that they're well ingrained in your brain, because every time you have a thought, it's a series of electrochemical signals being sent across a synaptic pathway in the brain, and you're strengthening it every time you practice it. And I tell patients, practice this on the good days, like when you're feeling okay, like not on a 10 out of 10 pain day, but on a pretty good day. That's when you want to be rehearsing those helpful narratives, because then they'll really stick in your mind and they will be ready for you on the hard days. So, practicing these things helps when you're in that unexpected kind of emotionally charged situation with a patient. You've got those things at the ready. Hold the belief that your patient can make changes, and hold the belief that you can help them do that. Find the confidence to be compassionate and hold your boundaries. You can do both at the same time. You've got to believe it, though, for it to happen. Connect with your values. I know Dr. Brandler talked about this in his talk. The why. It's not like we're a glutton for punishment and we want to have difficult conversations all day. We're doing this for a reason. We care. We want to help. We care about best practice. We care about, giving back to the world in some way. Ground yourself in that value right before you walk into that exam room, or even just throughout the day. It really does help prevent burnout, because you're connecting with what drives you to do this work. Setting realistic expectations for yourself is key. I've mentioned this already, but probably not going to solve the problem right here in this 10-minute visit. We're going to plant the seed for future change. Your patient might leave upset. If you are holding the line in a compassionate and supportive way, this is still a win. It's not a failure, because we can't control what they do, how they think, how they react to what we say. We can only control our own behavior. So we can decide we're going to set limits on ourselves. We're not going to push our boundaries. We're going to hold our boundaries with compassion. And that is still a win no matter what happens. Use your relationship as a resource. I've been talking about all these strategies for building rapport, and you can really leverage that. I work in the Department of Physical Medicine and Rehab, and I get a lot of referrals from within my department, and patients will say, gosh, I just love Dr. Friedman. I love Dr. Curtis so much. They just listen to me. We have such a good relationship. I really feel like I can trust them. Even if they're still dealing with a high level of pain, they have that confidence in that relationship, so they feel good about it. And we have to be willing to be uncomfortable. And this is kind of, where those DBT skills come in. Model for your patient the willing hands, the relaxed and confident body posture, soften your jaw, deepen your breath, really kind of breathe into the discomfort, because those mirror neurons are real. When you change your body language and your tone, that affects the patient on some level, whether you're putting words to it or not. This is a pocket card that is helpful for common traps that sometimes we can find ourselves in and how to kind of navigate your way through them. Because these are tough situations. So a patient might say, okay, well, do you want me to lose my job? Do you want me to be on the street? I want you to have safe and effective pain control. And it's my medical opinion that this medicine at this dose won't give you that. So you're going to do nothing for me. I'm confident that together we'll find safe and effective options. That's where you're offering that believable way forward. So are you accusing me of being an addict? I've never accused anybody of having diabetes, but I have diagnosed them with it. And that's what I'm doing here, diagnosing. This is in the context of opioid use disorder or the desperate traps. Don't bother with anything else. I'll just kill myself. One of the worst things that we can hear as clinicians. That changes the direction of the conversation. I need to ask you some more questions about your thoughts about suicide. You care, you want to know, you want to make sure that they're safe and hear them out. Or it's the end game, like they're just, all right, I'm done, I'm upset, I'm going to leave. And you can name that. At this point, I think we need to agree to disagree. I've laid out what I believe is the safest and most effective course of action. How do you want to spend the rest of our time? And you can say these things even in these emotionally charged moments by, again, using that body posture, that tone of voice, slowing down. It really helps to reduce that emotional intensity. And again, the patient might leave upset, but you've held the line in a compassionate way. That's a win. And you're going to see them again, or your colleague is, and you're going to be able to continue the journey together. Okay. Do I have a little time just to say thank you? I think I might. Okay. So obviously it takes a village to create a curriculum. And again, this was just my small part of it, but I wanted to thank all the people that have contributed to and supported this work over the years. Obviously, the incomparable Dan Warren was he was my rock during those compassionate limit setting roadshow years. And I have so much to learn from him. Laura Webster, our ethicist, had some excellent parts of the curriculum where she would talk about, triggers, internal triggers that we have as providers, being aware of the language that we use, really impactful stuff. I didn't include their portions because I can't do it justice. Dr. Auerbach and Justin Eckert in primary care were so helpful in a number of our talks. And Brandon is like the absolute king of mindfulness. And Justin did a really great role play for our inpatient hospitalist meeting, which I commend him for, because doing a role play in front of colleagues is a very stressful thing to do. Vera and Jenna are just nurse extraordinaires. Vera's one of the nurses in our clinic, and she and Jenna also did a role play for the CNE event. It was so good. Vera's just amazing with our population of chronic pain patients. And Jenna is looking to bring Beth Darnell's Empowered Relief Program to Virginia Mason, which I think will be a great addition. I hope that gets off the ground. And thank you to Donna Smith for always being a champion of this work and bringing me into the fold. And Andrew Friedman, my section head, is always so supportive of the work I do. And he probably knows way more about this topic than I do, so he should really be giving this presentation. Dr. Kita is such an important champion of innovation. She's always given me so much support over the years with all my crazy ideas. So thank you, Dr. Kita. And thank you, Rich Furlong, for suggesting that I present at Grand Rounds today. Like I mentioned, I presented to the Controlled Substances Guiding Team quarterly meeting, and he said, this could be helpful to kind of get the word out there. Instead of going on the road show, why don't we just have it be a Grand Rounds so that more people can tune in? And thank you to Justin Brandler for doing a lot of the legwork last month with your amazing talk. He's creating some wonderful things in the GI clinic that I'm excited to be a part of. And there's a lot of people that aren't pictured because they have left Virginia Mason, sadly, but suffice it to say, many talented people have contributed to this work, and I thank you so much. If you ever want to refer patients to me, this is the information for you for submitting those referrals. Please reach out anytime over email if you have follow-up questions or just want to consult or discuss cases. I'm here. So I think I will wrap it up there and see if there's any questions.
Great, thanks. Thanks, Jennifer. There are some questions. I just want to make one comment before we start. Jaron Brandenberger, when we were having a grand rounds on community about a year ago, talked about the secret sauce at Virginia Mason. And I got to say that group of pictures that you just showed is a picture of our secret sauce as well. Those are great folks, and they inspire all of us. There's one question here. Says, thanks for the talk. Is there any data on prevalence of BPD? I'm not sure I know what that is in chronic pain patient population.
I'm guessing that's borderline personality disorder. Yeah, okay, good.
Okay, thanks.
Yes. So we know based on what we learned about pain neuroscience that trauma, especially childhood trauma, is a risk factor for developing chronic pain in later life, simply because when a child is exposed to trauma and chronic stress, it modulates the nervous system's development such that the nervous system learns to be more hypervigilant and more aware. Because again, our brain's primary job is to keep us alive, save our life, keep us safe from threats, look out for any threats. And so when you're exposed to trauma in childhood, your brain's on high alert, and that nervous system gets wound up over time and more sensitized to potential threats. And these are often patients that go on to develop borderline personality disorder. And one of the best evidence-based treatments for borderline personality disorder is dialectical behavior therapy. As I mentioned today, just two of those quick little skills. But DBT is really essentially cognitive behavioral therapy with mindfulness and radical acceptance work. And that's why I include both of those elements in my group class series for patients, because almost all of them have been exposed to some type of stressor or trauma, not necessarily all childhood trauma, but it's very, very common. And so those skills and techniques help them. So that was a long answer to say, yes, they are often linked. And I don't have any data off the top of my head, but there's a lot of literature supporting that. Absolutely.
I have one question while we're waiting for other people to come in. And it's on scripting. And I obviously there's a little bias here because we're always taught all the scripting but then I find myself in certain circumstances, and sometimes it may just be at some get together, and somebody, you're making small talk, and you're obviously talking to somebody who's gone through appreciative inquiry, and they're using the same words every time. And how can we authenticate the scripting? Because oftentimes, especially when people are just learning this, they basically read your slides to the patients, and they say the same thing to people, and it seems less authentic. And maybe it's just with time, and you obviously have the skill to make it just be part of you rather than a script that somebody gave you. Do you have any suggestion for how they can get to that point?
It's such a good question. And you're right. If you were to just read the pocket cards to your patient, it would sound like a robot being very mechanical. And of course, we want to be genuine and real and in the moment. I think for me, I'll just share what helps is grounding myself in the belief, as I said in that first pocket card, hold the belief that your patient can change and that I can help them change, and that I'm going to do the best that I can to do that. And going in there with that, assumption of confidence really helps me be in the moment and not be so worried about what I'm saying and exactly how I'm saying it. The other thing that helps is to be very forgiving to yourself. You We tend to just self-criticize. We're constantly judging ourselves in our head, like, ugh, that didn't come off right. Ugh. Be genuine with it, like, oh, let me rephrase that. I think that didn't come out quite right. You always have the opportunity to communicate with the patient, clarify. So don't worry too much about doing it the exact right way, if you will, because you always have that opportunity to communicate further. That's really what helps me. And then, like you said, it is practice, just kind of like learning to be comfortable with the script so that then you can kind of make it your own. And that's why I encourage people to just practice it even on your own, like while you're brushing your teeth, think about it, just to get it ingrained so that you don't have to think too hard, and then you can really make it more genuine.
There's a great question that as an adult educator, I love. Are there opportunities for simulation training at VM for this incredibly important tool? I think it would be tools rather than just tool, but do you know of any? I know we have that capability. This sort of simulation training doesn't take any special equipment. It just takes the scripting and the feedback sessions. And do you know of any that are going on right now?
No, that's essentially what our compassionate limit setting roadshow kind of was, because we presented our information and then we would always do some kind of role play, like either the faculty would do a role play or we would have the participants do a role play and kind of try out the skills and then come back together. What did you learn? How was it saying things in this way? Did it feel different? So we'd kind of do that process work, which was really valuable. And I'd love to bring something like that back, and I think a virtual format would be good because then we could reach a lot of different people at different sites. So yeah, I absolutely would love to be involved in like recreating something along those lines because I think it's valuable, or I hope it is.
And we have done that many times in different settings, team steps and different, and role playing plays a role in some of our courses and things like that, but it might be interesting to get a special program in this regard if we have the wavelength to do that. There's one question: a patient threatens a lawsuit because they disagree with care, like the refusal to prescribe. How to proceed?
Yeah, it kind of goes back to those common traps cards. There's sometimes people will say, I'm going to bring a lawsuit. I don't know the data exactly. I just heard this not too long ago that the number of lawsuits that actually do get brought are significantly less than the number of lawsuits that are threatened. But that aside, I think what you work on is leveling with your patient and communicating, holding the line compassionately, really seeing eye to eye with them and saying, here's where I'm coming from. Let me hear where you're coming from. Oftentimes it's like when they're threatening something like a lawsuit or, a suicide threat, or they're storming out, they're just feeling like there aren't any other options in that moment. And so if you can kind of just work to open up some more options, even just by asking an open-ended question, that can be helpful. But again, we can't control what they do, how they think, how they react. We can only control ourselves, and we have to accept that, which is really hard to do. Finding peace with that reality is challenging, but we can do it. So that's kind of my 2 cents on that. And yeah, the connections class has a lot of these templates. You're absolutely right. Thank you.
I wanted to, we don't have any other questions right now. There's a lot of thank yous, and there's one, Dr. Kelly, you are a crown jewel of our VMFH team. I thought I'd tell you that. I want to highlight a couple of things you said that that bothered me in my career, my long career, in different aspects of care that I've seen given. One is your fawn response, the alarm system behaviors fawn response. I think that's such an important teaching point. I wish the residents would have to go through this. Just the wanting to be liked and to please, you just need to control that. And I loved the recovering people pleaser comment you made. It was just brief, but I love that. And then it also went down to the pocket card and realistic expectations. And I just wanted to reiterate one: your patient might leave unhappy or upset, if you are holding the line in a compassionate and supportive way, this is still a win. And I think that's so important. We have to practice that way, because if we just go to please, we cause so many more problems. And it's hard to do when you're first starting out. It's probably a little easier the longer you've been in practice, but I just wanted to emphasize that. I don't see any other questions, and we're nearly at time. I want to thank you. We will have this available, so you don't have to go on the road. You can just refer people to this, and we'll use it if we need. And again, we'll give it to our Common Spirit colleagues as well. Thank you very much, and we hope to. And remember, folks, that this may count as part of the requirements, so keep that in mind. Thanks.
Thank you so much.